uh, does not result in clinically important improvements after total knee arthroplasty compared with mechanical alignment, which in essence, like just the title of this article contradicts what Mr. Tawfiq has just mentioned. So after I present it, we will actually compare both concepts so that we all can understand what's currently going on and what to choose in the future. About myself, I'm currently working as a specialty doctor in Warwick Hospital, and I used to work as an orthopedic lecturer in Ain Shams University, Demirdash and Specialized Hospital. So to summarize this article, it will be a continuation to Mr. Tawfiq's presentation. We now have, like as we speak, in the world, novel techniques doing the total knee replacement, like how to align the total knee. This, in essence, has risen mainly because, as we all know, there is a consensus that 20% of total knee replacement are dissatisfied patients. We say that for unknown reasons, okay? There's nothing called unknown reasons. We just don't know what's going on, and we want to find out what's going on. The nice theory here is that we have been using the traditional gold standard approach, one size fits all, and we do our total knee replacement following the mechanical alignment. All of us up until now, we do the mechanical alignment for total knee replacement. This is what we have been taught. This is what we have been trained on, and this is what we know. Very, very rarely that we may meet someone who has tried the kinematic alignment or the anatomical alignment or the restricted kinematic alignment or even the functional alignment. However, sometimes we may achieve something like that by mistake, thinking that we are doing a total knee in a mechanically aligned way, judging the x-rays post-op. So in brief, this article comparing both options or both techniques. In the kinematically aligned total knee replacement, it's mainly a bony procedure. We don't want to do any soft tissue releases. We want to restore this knee to the pre-arthritic knee. If the patient was in varus, we want to restore it in varus. If the patient was in valgus, we want to restore it in valgus. If the patient was any phenotype from the 9 phenotypes Mr. Tawfiq mentioned, we want to bring this patient back to that phenotype, okay? So we are not looking at mechanical alignment here. So it's a custom-made, patient-tailored total knee replacement. Theoretically, this should abolish the 20% dissatisfied patients for unknown reasons. But realistically, we have not achieved that concept yet, because for kinematic alignment, we need to align the knee in the 3 axes: coronal alignment and sagittal alignment and axial alignment, okay? Achieving the 3 axes in one go, that's like divine, okay? So like Mr. Tawfiq mentioned, you need to have robotic, you will need to have navigation, you will need to have a lot of pre-operative investigations like 3D CT scanning with specific protocols, computer softwares to realign your knee and bring it to how it was before arthritis, and to predict how was it before arthritis, especially if the patient has arthritic knee on the other side. You don't have a reference for that patient. So you want to bring this knee back to its unique print, like fingerprint, before arthritis has developed. However, on the other side, the mechanically aligned tibial cut, we all know that we cut our tibia parallel to the anatomical or mechanical axis because they are the same. And then we cut the femoral cut 5 to 7 degrees in valgus to the mechanical axis of the femur. And then when we do this, we do that. We balance our gaps, flexion and extension, so that we can achieve good results. It achieves 80%. 80% in medicine is a good outcome, generally speaking. But we, as orthopedic surgeons, we have the ego to go for perfection, and hopefully we'll be able to achieve that once we have better understanding of knee phenotypes and how we can achieve these concepts or which one is the best for each patient. So in this study, they actually have done a very nice, simple study focusing on patient-reported outcome measure, the PROMs, and the ROM. So PROM and ROM, they focused on those two outcomes. They said in their article that the patients don't feel the p-value. The patient don't care about statistically significant difference between this and that. What the patient do feel is, am I happy or not? Is my knee working or not? So how to measure that? They followed the PROMs and the ROMs. The PROMs, we all know Oxford knee score, and this is the one they used in this article. And the ROMs is the range of movement, and they focused mainly on how much improvement we can achieve with knee flexion. This article was done in Canada, Ottawa University. It has been recently published, January 2025. First of all, let's start with the title. As you can see here, a big, long title, more than the 10-word rule, with a nice group of authors. However, it's clear and to the point. The authors are comparing a novel technique to the standard technique. They are focusing on the MCIDs. These are the minimum clinically important differences. So this is a statistical title or entity that is more recently used in publications to focus more on what will make a difference. So what is the minimum clinically important difference is what is important to the patient, what is clinically obvious to the surgeon and to the patient to be important. Like I said, they focused on the PROM, which is an obvious clinically important difference, and the ROM, the range of movement, which we can measure and we can tell. But the journal itself is the Clinical Orthopedics and Related Research. The impact factor 2024 is 4.4. The editor-in-chief is Professor Seth, and he has been a consultant for the last 20 years, retired in 2021, and he's now dedicated to research work. Editor-in-chief for this journal and for correlation journal as well. It's a peer-reviewed medical journal established in 1953 as an alternative to the Bone and Joint Surgery Journal. At the time, the Bone and Joint Surgery Journal was the only orthopedic journal, and this was developed as an alternative. Probably they were charging high fees. And then it is ranked as the 47th out of the 79 orthopedic journals worldwide, according to the observation of international research platform. So it's a reputable journal. And these are the group of authors. We have here one clinical research associate from UK, but has moved to Canada, and then 2 residents and 3 consultants. One of them is an assistant professor. And as you can see here, we have a big portion of presentations and scientific input from each single one of them. So the average would be, I would think, 30 articles with loads of citations, of course. The time lapse in this work, it has been received by the journal end of August 2024 and accepted beginning of December 2024, which is a couple of months, and then published online in January 2025. I believe Mr. Tawfiq's presentation, the article was published in 2021 by Makdesi et al. This article here, the time lapse is showing that they went through a very short rework. Like I said, it's a very simple meta-analysis, systematic review. No much fuss. They're not fiddling around with statistics and sophisticated stuff. Just as simple as such. Quick acceptance. This should suggest a good quality publication. Then we move to the introduction. The introduction was a bit long, but it showed the importance of the study. Again, it highlighted the 20% dissatisfied total knee replacement. In their introduction, they claimed that they are the first meta-analysis to compare to compare randomized controlled trials focusing on the minimum clinically important difference and not the p-value, which the patient doesn't feel. However, we will know later on that they themselves published other meta-analysis that compared RCTs focusing on MCID. The hypothesis was clear. So they focused mainly on range of movement, the ROMs and PROMs. And they were calculating the difference between both techniques, whether there will be difference or not. They assigned the minimum clinically important difference in range of movement as 5 degrees average and Oxford knee score improvement as 5 points. They didn't come up with that from the top of their head. This has been previously published in other articles as MCID for those two parameters and acknowledged, accepted. The methodology was a good methodology as well. They followed the PRISMA protocol. They had reasonable inclusion and exclusion criteria, and they highlighted the included RCT's risk of bias. And that was a very important point here. They used the Cochrane risk of bias tool to find out whether those RCTs they used in their meta-analysis are biased or not. They found that half of those RCTs, 12 in total, are low bias, meaning they are good. And the other half is actually moderate to high bias, which means that they are overestimating the benefits of kinematic knee alignments. They assigned 2 authors to collect data independently and cross-reference that for better like intra-study validation. And they converted the variables like the functional knee scores used in those RCTs to the Oxford knee score. The WOMAC score was used, the KOOS score was used, and other functional knee scores were used, but they converted that to the OKS in order to have like a generalized standard comparing all the studies together, which is a bit tricky, to be honest. And then they analyzed the relationship between the change in the range of movement and the change in function and pain. Again, the hypothesis will always suggest that if the range of movement improves, then the patient is not in pain and he has a better function or she has a better function. And this is the PRISMA protocol. They have identified 1,600 papers as like eligible for this. And then they have removed the duplication, ended up with 1,400 articles. It's a massive number. They went to screen all of that and they ended up with 19 articles with potential to be included and ended up with 12 articles only focusing on the PROMs and 10 articles focusing on the ROMs. Those 12 articles, 3 of them were in the USA, 2 in Australia, New Zealand, 1 in Canada, UK, Germany, Japan, and Iran. And 6 of them showed no differences at all in both PROMs and ROMs. And 6 of them showed favoring the kinematic knee alignment. For the statistics, again, they employed proper statistical tests, chi-square test and I-square test for heterogeneity. And this is an important thing to know as well. They used the random effect models if the heterogeneity is 25% more than 25%, or fixed effect models if the heterogeneity is less than 25%. So I need to tell you that the heterogeneity in this study is actually 75%. It's a massive heterogeneity, like there is no matching here between the RCTs used in this article. They presented the data in a very simple, clear way using the mean, range, 95% confidence interval, and the p-value. So this all made the article easy to read and to understand. I was lucky to have this article. When it comes to the results section, they included the articles that showed follow-up between 1 and 2 years, and those were 9 studies only. So out of the 12, only 9 were included. And the other 3, they showed no difference already between the 2 cohorts, although they were overlapping cohorts with other publications related to the same title here. Only 1 article showed that they achieved better kinematic results, and the total number of patients were about 850 patients, range between 46 and 200 in the different RCTs they used. However, there was no difference in the minimum clinically important difference, like there's no difference in PROMS statistically. Comparing the patient-reported outcome measure, the Oxford knee score, between those 9 studies, there was no difference. The follow-up in those studies was 5 years in 1 study, 4 studies follow-up for 2 years, 4 studies for 1 year, 1 study for 6 months, which is a very short study, and 1 study for 3 months from Iran. Very, very, very short study, so I wouldn't rely on that. 4 studies had no females at all in them, and those 4 studies showed no difference. So obviously males, they don't care much about what's going on. Both are fine. Each of the 12 studies are matched in numbers, the mean for age, the manufacturer on each group. However, all the 12 studies used in this meta-analysis are matched in the age only, the mean age only, and they differ on all other parameters. You can imagine that they had articles, randomized controlled trials using this manufacturer, other article using another manufacturer. Article has 40 patients, another article has 200 patients. So again, this gives a massive heterogeneity. However, they have gone the extra mile. So although they have not included all the studies in the PROMS, the Oxford knee score, they looked at the other studies. What kind of knee scores have they been using? So 3 studies showed no difference in the forgotten joint score. Forgotten joint score is another functional knee score similar to the Oxford knee score. And the 3 other studies showed no difference in the ECAL 5D visual analog scale, which is again another score for the knee function. However, when it comes to the range of movement, I wasn't really very happy with the presentation of the results. 6 pooled studies showed no flexion difference. Number of patients was very small compared to the first cohort, 388 patients, and 3 pooled studies commented on no extension deficit. So it's not commenting on flexion range, it's only commenting on no flexion deficit, like there is no fixed flexion deformity. And this included 230 patients. So in reality, this didn't mention 10 studies, as they mentioned earlier, included in the range of movement. This is only 6 studies commenting on the knee flexion. And when it comes to the discussion part, I was even more frustrated and disappointed. It is a very poorly written part in this article. It's a mere repetition of the conclusion. There is inconsistency in the data. They mentioned 10 RCTs for PROMs, and 6 for ROMs. However, like this is the reality. They mentioned 12 and 9 at the beginning. And in the PROMs, they quoted 2 meta-analyses, both favored kinematic. However, the minimum clinically important difference is still not different. And one of those 2 meta-analyses they quoted in their discussion published a follow-up update to state no difference. So again, they are using the publications that support their point of view. And in terms of range of movement, they quoted only 1 meta-analysis, and this has favored the kinematic, but again, the minimum clinically important difference was not different. In terms of limitation, they themselves put the limitation in their publication, and I can tell you now that is equivalent to 2 pages out of 6 published pages as limitations. Okay, a novel technique. We don't have enough information about it. We don't know how to implement that in real life scenarios properly. The 12 randomized controlled trials included in the PROMs and 10 only included in ROMs turned out to be 10 and 6 as previously mentioned. There is massive heterogeneity, and this can over or underestimate their results. So they themselves are not 100% sure about their results, and they mentioned clearly that the results need to be interpreted with caution. Different implants were used even within the same randomized control trial. You may find that this company is for kinematic alignment and the other company is for mechanical alignment. However, both companies have both options. 8 of the 12 studies reported receiving funds from the manufacturer or industry, and this is again high bias. PROMs converted to Oxford knee score is not validated yet. Like the method they used, which has been previously published, is not independently validated as a valid method that can tell you, yes, you are right, you can convert this score to that score, reflecting same results. And on their article, they have published previous meta-analyses that compare patient outcome in mechanical versus kinematic alignment, total knee replacement, and their overall conclusions as well. As you can see here, we have 6 publications. 4 of them showed no difference between the kinematic alignment and the mechanical alignment. 2 showed like favorable results with kinematic alignment. The minimum clinically important difference was used in this study by Van Nessen. Okay, so they mentioned and claimed that they are the first meta-analysis to use MCIDs, and they mentioned on their own publication that this meta-analysis by Van Nessen et al. Has used MCIDs. In their conclusion, they have recommended against kinematic alignment for several reasons. First of all, it's a novel technique. We don't yet have long-term established results like we do have with the mechanical alignment. We know now that we have reached the top, which is 80% good outcome from mechanical alignment. So at least we have solid evidence to tell the patients, if I do this for you, you are going to have 80% chances of improvement. And there are loads of uncertainties, like we don't know how to restore the knee back to its normal native like shape or phenotype, because we don't know what was the normal for this patient. We want to align the knee in 3 different axes, which is technically impossible if we are going to do it manually. We have to rely on like technology, sophisticated software, which means very, very, very high cost, custom-made PSI, etc. We need more level 1 standardized evidence in order to support the claim that kinematic alignment is better than mechanical alignment. There's a big, massive learning curve based on what I've just mentioned in order to align the knee in 3 axes, recreating a 3D model in space yourself, more costs, and the available is already well tested and revalidated so far. The reference part, however, was excellent. They had 57 references, more than 80% were within the last 5 years, good quality references and relevant to the topic. This article was cited 2 times so far in 9 months. And my appraisal for this study, is it useful? Yes, it is very useful. Why? Because it's a novel technique, novel concept. Surgeons are adopting it theoretically because it is actually like understood that if we can achieve this, then definitely, yes, I'm expecting better results. Is it reproducible? Yes, the study itself is reproducible. In real life, yes, it is reproducible. We can do that, but with difficulty, massive difficulty. We have to achieve the 3D alignment of a knee after total knee replacement. So in my opinion, my experience, I feel it's an extremely difficult way to do a total knee replacement unless we have more knowledge, more understanding, and better tools to achieve this. Is it reliable? This paper in particular, I don't think it's reliable. It needs validation, and there are a lot of methodology flaws that need negation. Is it applicable? Yes, it is applicable. They are advising against, and I'm happy with their decision. Will it change my current practice? No, I won't change, because they are recommending what we are all doing at the moment, which is the gold standard, mechanical alignment. There is no available consensus yet or guidelines up until that moment in the UK or worldwide on how to do a total knee replacement. My senior consultant I'm working with now has a common saying, which is total knee replacement is a procedure with the most unpredictable results. Again, because of the 80% success rate, 20% dissatisfaction. Again, there is no consensus to guide you or advise you do this or do that. My rationale why I said that is that this meta-analysis is a very well-designed meta-analysis, theoretical. The sample size was small and the cohort is inconsistent. First of a kind is a false claim. The data is less accurate, loads of limitations, poor discussion. They overlooked the systematic review component in their article. They said it's a meta-analysis and a systematic review. I couldn't see systematic review or much info or input from their side here. Massive heterogeneity again and massive bias. That's why my rationale was, as previously mentioned. My take-home message is different types of total knee replacement alignment exist. Mechanical alignment is the traditional gold standard, what we all do. Other types of knee alignment in total knee replacement includes the anatomical alignment of total knee replacement, kinematic alignment, restricted kinematic alignment, and functional alignment. We now understand more or less what is mechanical alignment and what is kinematic alignment. For restricted kinematic alignment is you try and achieve a kinematically aligned knee, but within limits. If the software is telling you that you need to put this knee in 15 degrees varus, I'm sorry, this is beyond the restriction here. We need to be within limit. They put limits for their kinematic alignment, which again doesn't make sense. That this doesn't sound like kinematic to me. Kinematic means that you are not doing soft tissue releases. You are mainly doing minimum bone cuts to restore the knee to how it was before. Anatomical alignment is you are trying to align your knee in an oblique joint line that is pre-assigned as 3 degrees valgus. That's it. Functional knee alignment, you are trying to produce a total knee replacement that will achieve the best possible function to this patient with the minimum bone cuts and soft tissue release, which is some sort of compromise between everything, mechanical, anatomical, kinematic, and it again tailored according to the patient. Sometimes you are doing an elderly, frail patient and you don't want to do massive big cuts, massive morbidity, longer rehab and recovery. So you can compromise by accepting a more or less within normal parameters. So again, there is no like guidance or specific range where I do my cuts, how I do my cuts is still evolving. There is no evidence to suggest a superior technique so far. Like I said, you may do a total knee replacement, you go to check your post-op x-rays, and then you are surprised, what's that, what did I do? And then it turns to be like it follows the kinematic alignment, or it follows the anatomical alignment, or it follows the functional alignment. You follow your patient is happy. So there is no superior technique yet. Kinematic alignment needs advanced technology. Preoperatively, in order to find out how was this knee, you may need MRI cartography to reconstruct the lost cartilage, relying on the other knee compartments, cartilage thickness, and then build up your knee alignment, and then that will be how it was before, predictions, estimations, and intraoperatively for sure, like the background here, robotic knee surgery, computer navigation, CT 3D protocols for sure, and PSI in most of the cases. So it's very expensive. And would the benefit justify this? That's what the MCID said. No, it doesn't justify. Mechanical alignment so far is the major widespread reproducible conventional technique with only 20% dissatisfaction. My advice is master the mechanical traditional gold standard technique before you jump and evolve and progress to the next stages. By that time, the science and technology would have developed to a certain limit or certain extent that will allow us to understand these concepts more, achieve better results than 80% satisfaction. And please, please, please do examine your patient well and thoroughly before listing them for a total knee replacement. Again, you need to predict the prognosis before offering the option for that patient, but the total knee replacement is the most unpredictable operation. And thank you very much. That will bring us to the end of my talk. I would really appreciate if you scan this QR code on the top right corner in order to give your feedback, and we can have the discussion.
Thank you so much, Ahmed. Again, one more comprehensive presentation on systematic critical appraisal.
Hello?
Yeah, can you hear me, Ahmed?
Yes. What do you say?
Yes. Yeah, I'm just saying thank you so much.
You're welcome.
Yeah. Well presented. And I think you went through a well systematic critical appraisal to the paper. So we have one question here from Hussam. He asked, did they pull the robotic and Jake instrumented total knee replacement and the meta-analysis?
Say it again. What's the question? Let me read that.
So Hussam asking, did they pull the robotic and Jake instrumented total knee replacement and the meta-analysis?
No, they didn't mention anything at all about details. All what they focused on is they were looking at the patient satisfaction. Are the patient satisfied or not? So they relied more on subjective parameters, not objective parameters.
Okay, not objective. Yeah.
You mean, Ahmed, have they spoke about the technique or just the alignment?
No, they didn't talk about the technique at all. All what they did is they collected the randomized control trials comparing both techniques, and then they collected the results of each randomized control trial to see whether it has surpassed their predefined minimum clinically important differences or not. They didn't look into the technique itself.
Ali and Ahmed, thank you so much. I think, Ahmed, your presentation was very thorough. You know, a lot of questions. You actually asked the question and answered it in your presentation, which is very, very good.
Thank you.
Yeah. Thanks, Ali. Thanks, Ahmed. That's very, very good. Guys, thanks for the attendance and for your time. And just to announce that this is running monthly, very regular since November. It's just second Friday of every month at 7 p.m. London time, 9 p.m. Cairo time. And we always welcome you as an attendee, or if you want to share and present a paper or appraise a paper, we're more than happy to do. Thanks so much for organization, and thanks everyone for your time. Sorry, I was just in the train, that's how I wasn't following. Perfectly done.
That's fine. Thank you.
I just would like to ask
everybody to, I just would like to ask everybody to submit the feedback.
Yeah, so once
so
guys,
I can send you certificates, please.
Yeah, once guys you finish the meeting, you will have a feedback through Zoom, and once you bought your feedback, attendance certificate will be sent to the email you would register with, or you bought in your feedback. Other than this, guys, when you register, they will send you an email with a link to come in with. For any reason, if you come off the meeting and want to come in again, just follow that link rather than registering again. One more time, just put your feedback. What's positive, what's negative. We're aiming to improve time after time. We need this journal club to evolve. And I promise you a very good accreditation by the next month. Will be a Royal College of Edinburgh accreditation by next month. So just wait for it. Yeah. Your feedback is essential for that.
Can I just ask Ahmed one thing, please, before he goes?
Sure.
Ahmed, thank you very much. It's a very thorough presentation. You've been thoroughly praising this paper. But it's for me that I'm a bit surprised that you agreed with the paper, even though that you've destroyed every evidence that they've used. And they said that you're actually saying that the paper has got a lot of heterogeneity in it. There is a lot of things that are wrong in the methodology that they've used, and therefore this consequently should mean that the results that they've come up with are not necessarily accurate. I agree. I give you I give and I concede to the idea that kinematic alignment is less understood. It's difficult to reproduce to some extent, and it needs further devices and all that technology. However, that being said, I find it very difficult to come to the conclusion to agree with their conclusion based on what they have presented as evidence to it. How do you
You're absolutely right. I didn't rely on their presentation. Like I said, like the design was fine, their intentions were fine, but their execution and performance was very poor. So I relied more on other published meta-analyses, like the one they actually put in their own publication. They put like 6 other meta-analyses comparing kinematic alignment to the mechanical alignment. 4 of them said no difference. 2 of them said favored kinematic alignment. And even those 2, one of them came up later contradicting their opinion, saying there is no difference. So 5 out of 6 are saying there is no difference. Only one, which is your randomized control trial, is saying that there is a difference. Again, like you said, I believe that at this point of time, it would be really amazing if we can achieve something like that 3D, 3-axis alignment of the knee back to how it was before. This is what every patient aspires, and this is what every surgeon dreams about. But to achieve this, in my opinion, with the amount of knowledge and tools we have now, is extremely important and difficult. Like, think about reality, like in the NHS or even worldwide. How can we achieve and popularize such a concept without?
Well, there is some evidence emerging that the medial pivoting, kinematically aligned knee, they do a lot better functionally, as you said, with the forgotten joint scores and the functional outcome scores. There is emerging evidence of that,
correct,
which supports this. So there is something there. I agree with you. There is limitation to the applicability in the current practice, especially if you're practicing on mass population or a public service. But this is the start, and then maybe it will evolve to become
yes,
something.
of course, I totally agree with you. So I'm not actually destroying the concept. I'm just saying there is no long-term results to rely on. In order to be or to perform a safe surgery, I would wait until it moves from the academic experimental stage to real life stage. By that time, the cost should come down, the methodology or the technique and the tools required should be more or less conventional.
True, I agree. And I think this is one of the disadvantages in the study that I have presented, is that it was only relying on soft tissue balance intraoperatively, which did not validate that into functional outcome scores. We don't know these patients, even though that they've measured it very thoroughly with the pressure sensors intraoperatively to make sure that they have achieved the soft tissue balance that they wanted. However, we don't know if these patients actually have done better afterwards or not. Functionally, we don't know. And it's a single center as well.
Pressure points intraoperatively, the patient is not weight bearing, so it just tells how you put the knee this way or that way.
Yeah, there is a variability there, isn't it? Yeah.
Okay, guys, very nice discussion. Okay, guys, so we are up to time. So, guys, thank you so much for your presentations. Thanks everyone for attendance and for your time. Hopefully, it was a fruitful, informative one. We'll wait for you second Friday of November for another very interesting papers appraised by very eminent surgeons. Thank you so much, everyone. I just remember you again of the feedback, and attendance certificate will be sent to you. Thank you so much for your attendance and have a good evening.
Thank you.
Thank you everyone for attendance. We'll see you next month.
See you next month. Thank you.